Bismillahirrahmanirrahim. Today we are going to discuss about the diarrhea, and particularly the diarrhea that is associated with the malabsorption. We know that diarrhea is a common condition that occurs as a complication of various intestinal diseases, and today we will discuss the two very important diseases: the celiac disease, which is an immune mediated disorder, and the cystic fibrosis, which is a genetically inherited disease. Diarrhea is when a person passes more than 200 milliliter of stool by volume per day. Now, this much excess fluid volume in the stool or feces may be due to increase in stool mass, or it may be due to increased frequency. The person repeatedly and attend the washroom, and or it may be caused by increased fluidity, which is the water content of the stool. So any of the three, the increased stool mass, increased frequency, or increased fluidity, may result in diarrhea. Dysentery is a small volume bloody diarrhea that is commonly caused by the entamoeba histolytica, which results in amoebic dysentery, or it may be bacterial diarrhea, which is called as the bacillary dysentery. The diarrhea is a common complication of many intestinal disorders. For example, it may be a complication of the bacterial or viral infection, which bacterial infection mostly result in exudative diarrhea. The viral infection, for example, the rotavirus infection in children is very common in our country. Diarrhea may also be caused by the inflammatory conditions which causes inflammation of the intestinal tract. Diarrhea may also be a prominent symptom in intestinal ischemia, for example, ischemic bowel disease. Diarrhea may be due to deficiency of various nutritional contents in the food. And the very important diarrhea that we are going to discuss is the malabsorptive diarrhea. Malabsorption means decreased absorption of the intestinal contents. We know that digestion and absorption mainly occur in the small intestine, particularly in the duodenum and in the jejunum. So this digestion is assisted by the pancreas, by the gallbladder, and by the liver. So in conditions which lead to pancreatic insufficiency, by that we mean that the pancreatic enzymes are deficient. For example, the pancreatic lipase, pancreatic amylase, and other proteolytic enzymes. So the deficient pancreatic enzymes will lead to incomplete digestion of the food in the small intestine, and it will result in diarrhea because the contents in the intestine, they are retained there and are not efficiently digested. Malabsorption may also be seen in celiac disease, which is an immune mediated disorder in which the intestinal mucosa is destroyed by the immune cells. Crohn's disease is one of the two inflammatory diseases of the large intestine in particular. The other is the ulcerative colitis, and Crohn's disease is also an immunologically mediated disorder. So whatsoever, but if there is a deficiency of the pancreatic enzymes, or deficiency of the secretions of the accessory organs that assist in digestion, or if there is a problem in the intestine itself, there will be defective absorption of intestinal nutrients, the macronutrients and the micronutrients. Particularly in malabsorption diarrhea, the fats are not efficiently absorbed. We know that for the absorption of packed fats, the pancreatic lipase and the bile from the gallbladder and liver, they are important and they assist in the digestion and absorption of fats. Similarly, when the fats cannot be absorbed, the fat soluble vitamins also will become deficient. In addition to fats and fat soluble vitamins, the water soluble vitamins, which are, for example, vitamin B complex and other vitamins, they are not efficiently absorbed. So here we can see that a deficiency of the vitamins will occur in the body, and vitamins have got important roles in various metabolic processes. The fat soluble vitamins A, D, E, K, and B complex and group and other vitamins are not absorbed. The proteins, carbohydrates, and fats, they are the macronutrients, and they are very important for energy and many processes and are utilized in the body. Additionally, the electrolytes like sodium, potassium, calcium, chloride, they are also not absorbed. And the micronutrients in the form of minerals and vitamins are not efficiently absorbed, and their deficiency will occur. And the absorption of water may also be affected, and the person can suffer from dehydration. So whatsoever in malabsorption diarrhea which occurs due to malabsorption of all these contents, it will lead to steatorrhea. The fats in the intestine are not absorbed, they are retained and they are passed in stools. So the presence of fats in the stool is, this condition is known as the steatorrhea. Automatically the patient will lose weight. If the condition is chronic, the patient may also suffer from anorexia, loss of appetite, and there can be abdominal distension, flatulence, and indigestion, and in chronic condition it will lead to muscle wasting. Now, before going into the details of the malabsorption diarrhea, let us recall the digestion that occurs in the small intestine. We know that the macronutrients, carbohydrates, proteins, and fats, they are broken down into their absorbable forms in the intestine. For example, the carbohydrates that we use are in the form of starch or polysaccharides. So, first in the mouth, the food is chewed, which is a type of chemical digestion, and the pancreatic amylase break down the polysaccharides into smaller saccharides. Then in the small intestine, particularly in the duodenum, the polysaccharides broken into disaccharides like maltose, sucrose, and lactose, the milk sugar. Now, in the terminal digestion, the disaccharides are broken down into monosaccharides, and this is the these are the absorbable parts of the carbohydrates. Maltose is broken down into two molecules of glucose. Sucrose is broken down into glucose and fructose. Fructose is further broken down in glucose, and lactose is broken down into galactose and glucose, and galactose also will be broken down into glucose in the body. Now, once The carbohydrates are absorbed, they then pass through the epithelial membrane of the cells to enter the blood to be utilized by the body. The proteins, digestion of protein starts in the stomach, and the stomach pepsin, which is derived by the cleavage of pepsinogen by the HCl, this pepsin starts breakdown of the polypeptides into dipeptides and monopeptides and ultimately amino acids. And amino acids are directly absorbed into the blood. The digestion of the fat is a little different. We know that fats are not soluble in water, so the bile secreted by the gallbladder and liver, it causes emulsification of fats. And then the pancreatic lipase causes breakdown of the fats, mainly triglycerides, into glycerol and 3 fatty acids, triglycerides. And we know that they are not soluble in water, so they are absorbed into the lymph, not into the blood directly. And in the blood, they are carried in the form of various lipoproteins. We know the lipoproteins, which are the carrier proteins for the fats, and these are the chylomicrons, VLDL, very low density lipoproteins, LDL and HDL. The fluids and electrolytes are absorbed by various uh, diffusions into the blood and are carried in the blood then to be used where they are needed. So here we can see that the three phases of digestion, one is the luminal digestion that occur inside the intestinal tract, the terminal digestion that occur at the brush border of the intestine, and then the transport of the nutrients through the cell membrane. So a problem can occur anywhere in these positions. Either there may be some defect in the digestion, luminal digestion, or there may be a problem in the terminal hydrolysis or terminal digestion, or there may be a problem in the transport, transepithelial transport, and problem anywhere in these various phases can lead to malabsorption. Now we classify diarrhea into 4 types. In secretory diarrhea, what happens that fluid is secreted from the intestinal wall, blood flowing in the intestinal wall into the lumen of the intestine. And in this condition, the diarrheal fluid, it is isotonic. By that we mean that it doesn't exert any osmotic pressure on the fluids in the blood of the intestinal wall. And one thing important here is that this type of diarrhea will continue even if the patient is fasting. The osmotic type of diarrhea, which is commonly seen in lactose intolerance or lactase deficiency, in this type of diarrhea, what happens that there is the enzyme lactase is lacking, and the lactose is not digested. So what happens that the unabsorbable carbohydrates, they are retained in the intestine and they exert an osmotic pressure. By that we mean that they are hypertonic as compared to the blood plasma, and they will pull fluid from the blood into the lumen of the intestine. So this is also known as the hyperosmolar diarrhea. And in this type of diarrhea, if the patient stops eating, particularly if he stops eating fats, the diarrhea will abate. The malabsorptive diarrhea results from the unabsorbed nutrients, and in this type of diarrhea, particularly the fats, they are not absorbed, either due to pancreatic deficiency or some other problem, but the fats, they are retained in the stool, and the presence of fats in the stool, this condition is known as the steatorrhea. And mostly this type of diarrhea, it will abate when if the person is fasting. The exudative type of diarrhea is mostly caused by inflammatory conditions and bacterial infections, which cause inflammation of the intestinal mucosa. And in this type of diarrhea, where systemic signs symptoms are also present, it is characterized by the presence of pus and blood in the stools. And this type of diarrhea also will persist even with fasting. So the two types of diarrhea, the osmotic diarrhea and malabsorptive diarrhea, they will stop when the patient stops eating. While the secretory diarrhea and exudative diarrhea, they will persist even if the person is fasting. Now coming to the diseases, first of all, we discuss the celiac disease. The celiac disease is also known as the gluten enteropathy, and it is also known as the celiac sprue. Actually, the celiac disease, it will occur particularly in the genetically susceptible individuals. And what is the problem with these patients? That they are hypersensitive to the protein gluten, which is present in wheats, rice, and uh, various types of grains. Now what happens, that the immune system of the persons show sensitivity to this gluten protein. Actually, this gluten protein, when it is broken down by the pancreatic proteolytic enzymes in the intestine, one of its metabolic product, which is a small polypeptide and which is known as the gliadin. The gliadin is the major culprit which causes celiac disease. And the immune reaction that develops against the gliadin, this immune reaction will cause damage to the intestinal villi. The intestinal villi, which are normally elongated with shallow crypts, they become flattened, and this type of situation and damage to the intestinal epithelium will result in severe malabsorption and the associated complications of the malabsorption. Moreover, research has also shown that patients of celiac disease, they show an increased risk for certain malignant conditions or cancers, for example, enteropathy associated T cell lymphoma and small intestinal adenocarcinoma. Fortunately, when the person having celiac disease is sensitive to gluten, if the person remove gluten from his food, the symptoms are improved. And this person uh, is supposed to be on a gluten-free diet. Now going into the little further details, when we take gluten, which is a protein in our food like wheat, grains, rice, what happens, that the gastric, pancreatic, and small intestinal proteolytic enzymes or proteases, they will break down this protein into smaller peptides. And the peptides are then further broken down into amino acids to be used by the body. And one of the smaller peptide is known as the gliadin. Now, this gliadin cannot be degraded by the proteolytic enzymes into amino acids, and what happens, that the enzyme tissue transglutaminase, tissue transglutaminase enzymes will remove one amino acid portion of this gliadin, or it will replace one amino acid portion, and this process is known as the deamidation. And the gliadin is now known as the deamidated gliadin. It is said that people with human leukocyte antigens DQ2 and DQ8, they are at increased risk of developing the celiac disease. Actually, these human leukocyte antigens, they code for the major histocompatibility complex proteins. The major histocompatibility complex molecules are MHC1 and MHC2. Here, the gliadin is taken up by the immune cells like antigen presenting cell like macrophage, and it is further broken down and processed in the cell. And a part of this deamidated gliadin is presented with MHC class 2 molecule. This is a red flag for the inflammatory cells. So what happens that by presenting the deamidated gliadin, a portion of the deamidated gliadin with MHC2 molecule to inflammatory cells, the inflammatory cells, they are activated and recruited, particularly the CD4 positive T helper cells. Once activated, these CD4 positive T helper cells release cytokines, and these cytokines, they will damage the intestinal epithelium. Additionally, these cytokines also stimulate the B cells. The B lymphocytes that are stimulated and activated, they will be transformed into the plasma cells, and we know that the plasma cell will secrete antibodies. The three types of antibodies that are secreted by the plasma cells are known as anti-gliadin antibodies, anti-endomysium antibodies, and anti-tissue transglutaminase antibodies. The role of these antibodies in the pathogenesis of celiac disease is not fully understood. However, these antibodies play an important role in the diagnosis of the disease, and they provide a diagnostic tool to diagnose the celiac disease. The anti-endomysium antibodies, endomysium, we know that it is the connective tissue cover for the muscle fiber, endomysium, perimysium, and epimysium. So actually the basic reaction, immune reaction, occurs against the connective tissue that is present in the lamina propria of the mucosa. We know that the intestinal wall is composed of the layers from inside the mucosa, submucosa, muscular layer, and the serosa. And the mucosa itself consists of epithelial cells and the lamina propria and the muscularis mucosa. And the lamina propria contains connective tissue. And actually, the immune reaction develops against this type of connective tissue. So the antibodies that are produced, they will attack the endomysium around the smooth muscle fibers mistakenly, right? So here they can also give rise to the disease known as the herpetiformis dermatitis, in which inflammation occurs against the by the antibodies they develop against the endomysium. So the overall pathogenesis, what happens, that the gluten is proteolytically broken down, and one of its peptide, gliadin, which is antigenic, it is taken up by the antigen presenting cell, is degraded, and a part of it is presented with MHC class 2 proteins to the CD4 positive T helper cells, and these cells release cytokines like interferon gamma and tissue necrotic factor, and they will cause inflammation in the intestinal mucosa and will cause destruction of the epithelial cells. Additionally, the T cells also activate the plasma cells, which are transformed into uh, B lymphocytes, which are transformed into plasma cells, and they start releasing the antibodies, the anti-gliadin antibodies, anti-endomysium antibodies, uh, and the anti-tissue transglutaminase antibodies. And these antibodies, they help us in the diagnosis of the celiac disease. One important thing that I want to mention, that this gliadin also stimulate the intestinal epithelial cells. And what happens, that the epithelial cells which are stimulated by the deamidated gliadin will secrete interleukin 15. And this interleukin 15 will activate the CD8 positive T killer cells. And these CD8 positive T killer cells also take part in the destruction of the intestinal epithelium. So there are three mechanisms running: activation, cytokines released by the activated T cells, antibodies produced by the B lymphocytes, and activation of the CD8 T killer cells. Under the microscope, normally in a healthy intestine, we see elongated villi with shallow crypts. These crypts are very important because they contain the stem cells, and these stem cells will differentiate into uh, continually into the epithelial cells, which are actually labile cells, and they are continually shed and being replaced by the newly formed cells by the proliferation of the mature epithelial cells, and also to supply of the new cells from the stem cells. But in celiac disease, what happens, that the inflammation and immune mediated reaction will damage the villi. The epithelial cells are destroyed, and the villi, they are flattened. They are no more elongated villi, but they get flattened. And the crypts, which normally are elongated, they becomes like deep excavations. In the healthy intestine, the crypts are usually shallow, but here they are hyperplastic and uh, comparatively different and longer than the normal crypts. The villi, they are flattened, and there is, uh, since inflammation occurs, so there is lymphocytic infiltration. So how do we diagnose celiac disease? Simply, these patients, most of them, they have uh, moderate to severe symptoms: diarrhea, indigestion, flatulence, anorexia, weight loss. So what happens, we do serological tests to serologically test for the antibody immunoglobulin A, known as the tissue transglutaminase antibody. And normally the concentration of this antibody, it should be lower than 40 units per milliliter. But if the concentration is greater than 40 units per milliliter, it indicates the presence of the celiac disease. However, other conditions should also be excluded. For the confirmation, we do endoscopy, and through endoscopy we take a biopsy, and we see the cellular changes, the elongated crypts and flattened villi, and we can confirm our diagnosis if we do see and find these histological changes which are consistent with that of the celiac disease. Very simple. And finally, if we strongly suspect the celiac disease, we put the patient on a gluten-free diet. And soon we come to know that the patient symptoms and signs, they start improving. So this will confirm the diagnosis of the celiac disease. Now we go to the second disease which causes malabsorptive diarrhea and which is associated with malabsorption, and that is the disease known as the cystic fibrosis. By cystic means fluid filled sacs, and fibrosis means excessive formation of connective tissue. So this cystic fibrosis is taken from the effect of the disease in the pancreas. But this disease also affects the lungs as well as the sweat glands. And the cystic fibrosis is a genetic disorder. It is an autosomal recessive condition and it is associated with the CFTR gene. Cystic fibrosis transmembrane conductance regulator gene. So what is CFTR gene and what is its function? The CFTR gene encodes the protein known as the CFTR protein, cystic fibrosis transmembrane conductance regulator protein. And this CFTR protein, it is a channel protein. This channel protein, it in the cell membrane, it pumps chloride ions across the cell membrane. Automatically, when the chloride ions are pumped across the cell membrane, they are followed by sodium and water. And the cells that secrete into the ducts of the exocrine glands, if they are deficient with this channel protein, the CFTR protein, they will be unable to pump chlorides, sodium and water. And the result will be that the secretions in the duct secreted by the cells, it will contain little water and it will be a thick secretion. So what happens that the presence of this thick secretion, if it is in the pancreas, it will cause problem. It can obstruct the pancreatic ducts, and if the pancreatic ducts are obstructed, the bake flow of the pancreatic enzymes like pancreatic lipase, it will cause digestion and damage of the pancreatic tissue itself. If this thick secretion is present in the mucus in the respiratory airways, the ciliated cells and the cilia of the cells in the respiratory airways, they will be unable to uh, make this mucus expectoration. It will become difficult for them because the mucus is so thick, it cannot be cleared by cilia and provides a media for bacterial infections. However, coming to the sweat glands, here a reverse condition occurs. In the pancreas and in the lungs, the chloride ions are not transported out the cell into the ducts. But here a reverse condition occurs. The chloride ions are not allowed to enter these cells and they remain in the ducts of the sweat glands. So the presence of excess chlorides, water and sodium will cause excess sweating, which may, in conditions of stress, may lead to dehydration. And mostly, a small child with cystic fibrosis, his or her mother will say that when I taste the skin of the child, it is very salty taste, which is one of the important tests when we make diagnosis of the cystic fibrosis. So here the chloride ions are not allowed into the lumen of the ducts, but here the chloride ions are not allowed to be reabsorbed and they are excreted in the sweat. Now, summarizing the cystic fibrosis, we know that it is autosomal recessive disease, and in autosomal recessive disease we need two mutated genes. In dominant diseases, one mutated gene is sufficient to cause the disease, but for the recessive diseases, we need two mutated copies of the gene. For example, if the father is having one normal and one mutated copy, and similarly, if the mother is having one normal and one mutated copy, so for the child to develop full-fledged cystic fibrosis disease, both the mutated genes, one from the father and one from the mother, should be inherited. People with one mutated gene and one normal gene, they are supposed to be the carriers, but they will not suffer from disease. Only the child who inherits the two mutated copies will develop the full-fledged disease. We know that this is due to mutation in the CFTR gene, which is involved in chloride transport across the cell membrane. And when this CFTR gene, which coats the CFTR protein, if it is defective, what will happen? The chloride will not be passed and pumped across the cell membrane. So if we see the pancreas and lungs, what happens? That the chlorides, which is normally followed by water, is not secreted and pumped into the lumen of the duct. And what happens? That in the pancreas, the secretions, they become thick and they can block the pancreatic duct. Now, this type of disease particularly is seen in children. And here we take 3 patients. If it is a neonate, what will happen? That the first stool of a newborn baby known as the meconium. So if the newborn baby suffers from this mutated gene and mutated protein, what happens? That the meconium of this child, because it lacks water, it will be so much thick and stuck in and adherent to the intestine that it will not be passed. And sometimes this leads to meconium ileus, and we know that the patient may be presented to the surgical emergency. If we take the early childhood, what happens? That the thickened secretions in the pancreatic ducts, suppose if they cannot be passed into the small intestine, there will be a backflow. And we know that the pancreatic enzymes, pancreatic lipase, it will cause digestion of the pancreatic tissue itself, and it will cause acute pancreatitis. And if there are repeated episodes and attacks of acute pancreatitis caused by the presence of thick pancreatic secretions in the pancreatic ducts, ultimately it will lead to chronic pancreatitis, and this is the very proper site to which we apply the name cystic fibrosis, because this is the chronic pancreatitis in which, due to chronic inflammation, the fibrosis and scarring occurs, and we get the picture of fluid-filled cysts, and the areas where there is extensive fibrosis and scar tissue formation. So this will be the picture, particularly in chronic pancreatitis. Automatically, the lack of pancreatic enzymes, it will lead to malabsorption and the presence of fat, particularly the lacking pancreatic lipase will let the fat retained in the intestine and passed in stool, leading to the steatorrhea. Now, coming to the lungs, we know that the airways, they have ciliated cells, columnar epithelial cells with cilia, and these cilia, they play a very important role in clearing the mucus from the airways, because the mucus contains debris and various bacteria and microorganisms, and the cilia in these ciliated columnar epithelial cells, they continually clear the airways of the mucus, and this is known as the mucociliary action. Now what happens that if this mucus becomes very thick, as occurs in cystic fibrosis because of lacking chlorides, sodium and water, it will become so thick that the cilia are unable to clear this mucus, and it will be retained in the respiratory airways. And since we know that this provides a very favorable site for the colonization of bacteria, and the person can develop symptoms of cough, fever and other uh, other sign symptoms related to the respiratory tract infections. This type of situation is commonly seen later in childhood. So, cystic fibrosis in the sweat glands, it prevents the reabsorption of chloride, which is followed by sodium and water. More chloride, sodium and waters are excreted in the sweat, and this in severe conditions are when the person is exposed to a stress, the person can become dehydrated as due to excessive sweating. In the GI tract and pancreas, the thick pancreatic secretions may cause duct obstruction, leading to acute pancreatitis, chronic pancreatitis, and automatically lacking pancreatic enzymes, it will lead to malabsorption. In the lungs, the absence of chloride, sodium, and water uh, in the mucus cause the mucus very thick and hard for the cilia to clear it, and it may lead to uh, the development of various respiratory tract infections. How to diagnose cystic fibrosis? Very simple test. The mother tells you that my baby's skin is very salty, and if you check it, you will taste salt in the sweat of the child. This is a very simple test, and it gives a clue uh, to the presence of cystic fibrosis disease. And for the confirmation, uh, we will do genetic test and to uh, confirm the presence of two mutated CFTR genes, because this is a recessively inherited type of disorder. So, summarizing that what we said, that diarrhea can be secretory, osmotic, malabsorptive or exudative. Celiac disease is an immune-mediated reaction of the immune cells against the gliadin, which is the breakdown product of the protein gluten present in grains, rice and wheat. And the mechanism behind the diarrhea in celiac disease is the damage and destruction of the brush border surface area of the intestine. And mostly when more and more epithelial cells are destroyed, the uh, newly forming cells get little time to get mature and to function efficiently. The cystic fibrosis here, the malabsorption is associated due to pancreatic insufficiency, due to CFTR gene and CFTR protein, and which causes deficient chloride, add sodium and water due to defective chloride transport across the cell membrane, and the intestine will receive little pancreatic secretions, little pancreatic enzymes, and it will lead to the uh, delay or defects in the breakdown of the intestinal nutrients, and will give rise to the malabsorptive diarrhea. Thank you very much.